Progress in spine surgery comes from a willingness to rethink what is possible. Scientific Session 10 explores how endoscopic techniques are moving from niche applications into everyday practice. This session examines the expanding role of endoscopy across the spectrum of spine care. We begin with the perspective of a deformity surgeon adopting endoscopy later in his career, followed by technical pearls for both uniportal and biportal approaches. This program continues with advanced techniques, including uniportal decompression for cervical thoracic stenosis and endoscopic intradural tumor resection. We conclude by highlighting how surgeons at every stage can safely and effectively integrate endoscopic strategies into their practice, continuing to advance the quality of spine care at the Spine Summit.
Thanks for having me. Disclosures, I don't know if these are particularly relevant. I think it's important to understand my background. Had very reasonable training. I was very intrigued by challenging surgeries and deformity in particular. So when I graduated, I joined a group of 30 providers, and 8 of us did spine, and my role in that group was to do the most complex surgery of the complex. So these are just case examples of a very tight deformity curve in somebody with Charcot-Marie tooth disease, a flat back deformity, and a near spondyloptosis, an infected and previously instrumented patient, which all were fixed in various different ways, PSOs or sacral dome osteotomies. And part of my career was really dictated by gathering data, and thankfully the QOD database helped guide me to focus on outcomes rather than income. And I went to NASS in 2017. This was the turning point for me when I saw a thoracic disc herniation that was calcified. And they asked us as an interactive, how would you treat this? And of course, of a deformity guy, I was going to do a transparticular approach, take out part of the vertebral body, push the bone, the piece of bone into the, and then I was going to do a fusion. It wasn't how many screws I was going to put in, or if I was going to put screws, it was how many. And so I went down the rabbit hole of endoscopic surgery. I was trained by Dr. Telfian. I got a mentor, went and visited Dr. Galgly, and then started performing endoscopic surgery. And as I did this, it was very clear to me in my group that my role there was the deformity guy. So there was no way to really become an endoscopic guy in that group. So I just decided to move. So I moved to a very nice place and performed largely endoscopic things and do some more outdoorsy type of activities. And rather than just tell you how my practice has changed, I thought I would just show you cases that I would previously have fused that I now treat endoscopically. So this is a patient who has an isthmic spondy, which we're all familiar with, but doesn't have bad radiculopathy, in fact, hardly any, mostly back pain. But she trains horses for a living and can't get on a horse because every time she gallops, it basically impinges the pars fracture. So I performed a medial branch transection, which is a denervation procedure that innervates both the pars area as well as the facet joint. So this is the L5, or the medial branch of the L5 transverse process. There it's being transected. Once it's transected, the pain generator or this signals from that pain go away because the electrical signal's been cut. And then this is the S1 medial branch transection. Again, you can see the nerve very clearly. There's the nerve. And through scope, this is a bloodless operation. You can find the anatomy very reliably, and this works way better than it should be. This is her 3 weeks post-op on one of her prized horses, doing a trial barrel run. And she understands that there may be a potential to have a fusion one day, but was unwilling to accept that as a course. And she's a number of years out and is still very, very happy. This is a 64-year-old guy with a degen scoli. I would have probably done a previous T4 to the pelvis on him. Has primarily an L4 radiculopathy. So I shallow dock in the foramen from far lateral approach, open the foramen, decompress the foraminal area and remove the tip of the SAP. So if you can find the tip of the SAP, that's the source of the impingement on the exiting nerve root. And you can see we're just working through the far cortex. There's the tip of the SAP right there. And then this is the look at the L4 nerve root after we're done. And how do you know you're done? You know you're done when the exiting root has a pulsatile look and all the blood vessels are back on the exiting root. This similar gal, retired anesthesiologist who had a degen scoli, exiting L4 nerve root problems, but both combined with a bone spur as well as a disc herniation. And you can see, we won't bore you with the bone spur removal, but rather just the disc portion of this, which was underneath the L4 nerve root, and then a little bit work to complete that. But overall, very happy. She had a foot drop that had been pretty long-standing, actually, before we started this, and in the recovery room, she had marked recovery. This is a 48-year-old who has neurogenic claudication, grade 1, bordering on grade 2 spondylolisthesis, and fairly significant stenosis. And her issues are she really doesn't want to miss work. She relies on her income to be the breadwinner in her family. And so the options here for me was a ULBD, which is a unilateral approach, bilateral decompression, versus what I call the EndoX. It's a dual approach, so over the top on both sides, and it allows you to completely preserve the facet joint. So you don't violate the facet at all because you're docking in the midline. So this is me standing on the left side of the patient to decompress the right nerve. So I'm going over top in a declining decompression. So as we cross over, we will basically remove the undersurface of the facet joint. You can see the IAP and the SAP. This is working right at the base of the pedicle. And then here is the exiting L5 nerve root on the right side. That's a pretty good view of it. And this is typically how it looks in the operating room. You know, it's not a bloody mess. You can visualize the things very nicely. And then in this case, we actually perform the opposite side as well. Those are the views of the exiting decompression. From the right side, you can't tell where you've been in until you make your foraminotomy. Once you've made your foraminotomy, about half the work is done because you've been there on the other side. And then you just go over the top, decompress, remove the ligament and flavum, decompress the exiting root. There's a couple of little adhesions. Similarly, make sure it's decompressed and the exiting root is fully decompressed. So this is a before and after MRI. I think you'll agree with me that I'm not trying to deceive you by where the cut is taken. The vessels are in the same place, the iliopsoas is the same place, the pelvis is the same place, and we haven't really violated the facet joints. And she's awfully happy because she went on my website and dropped a review and said that we had changed her life. And the last case I'll present is a 56-year-old gentleman who was told he needs a 4-level fusion, and he was unaccepting of that. He does have a degenerative scoliosis. He's got collapse on the left side. The L5 nerve root is the problem on the left. Unfortunately, he's also had a previous decompression at the 4-5 level, lateral recess stenosis, and his exiting L5 nerve root has stenosis as it exits the L5S1 frame. And so both 4-5 lateral recess and the 5-1 level. So I did an over-the-top approach from the 4-5 level to decompress both 4-5 level as well as the exiting L5S1 nerve root. So there's the decompression of the 4-5 level. Here's the 5-1 level. This is a look at the 5-1 level. Let me get stabilized here. You'll see the S1 and L5 nerve roots. This is the IAP, SAP, and facet joint. So I'm removing the SAP from inside the canal out. So I'm inside the canal, working my way out above the L5 nerve root. You'll see here's the L5 nerve root. And as we look out, see the last couple of little grasps of soft tissue above the exiting root. And then I'll just put my probe all the way out onto the pelvis, proving his L5 nerve root's decompressed. So I call this the EndoX high-low, which is high entry, low exit. So I'm entering at the 4-5 level, exiting at the 5-1 level. So I think this is proof that you can teach an old dog new tricks. Thank you.